There's just one thing I'd like to tell the host that there are some videos of patients, and I have not taken consent for showing them except for teaching purpose. So recording of those videos is not allowed. If somebody records and then, puts them on the net and all, that will not, it might be objected by from the patient.
Good evening. I hope you can all hear me. You know, these are the difficult times due to the COVID pandemic that we are all dealing with. You and I, each of us is doing our best to overcome this pandemic. When you do step out of your house, only if it is necessary, wearing the right mask, making sure you keep the safe distance. And of course, when you are sure about your hand sanitization, you're not only protecting yourself, but you're protecting everyone else around you, your family, your friends, your community. That is the only real way that you and I are going to overcome this pandemic. But while we are doing that, life doesn't stop. Life goes on, and several newer methodology of doing things comes through. So today, you and I will look at how do we learn, how do we manage several groups of conditions. On behalf of the Neuroaid and the Research Foundation, let me welcome each one of you to this wonderful evening. The Neuroaid and Research Foundation is a not-for-profit organization which was founded a few years ago, primarily to support and promote high-quality neurorehabilitation. Most of us are aware that neurological disease and neurological disabilities often require long-term, prolonged, and often complex kind of rehabilitation, which needs to be continued. And many of the poorer people may not have the wherewithals to have the access nor be able to afford that kind of therapy, which is paramount in the recovery. And that was the basis on which the Neuroaid and Research Foundation was formed by a few colleagues and sustained very strongly by the passion of Mrs. Raji Chandru. And our aim is to make sure that the lack of rehabilitation should not be hindering the recovery of somebody. This evening, we'll be talking about Parkinsonism, called Parkinson disease, called the shaking palsy, among several other names. You and I know that at least one or more friends or family have suffered from this chronic and quite often debilitating condition. Several million in the world suffer from this condition. In India, the conservative estimates peg the figure at over 1 million people who suffer from this condition. What happens in Parkinson's disease? We all know that it's a condition which affects the central nervous system. It affects the movement of the individual. It can cause a lot of shaking or tremors, as we call it. It causes a lot of stiffness or rigidity, as we know it. It slows down the movement of the individual. It makes walking very difficult. As the disease progresses, people might develop depression, anxiety, dementia, emotional and sleep disorders. To discuss this condition, neurologically, what it is and what can be done, and to see how valuable good quality rehabilitation is, we have two experts with us today who will speak to us and then address a lot of our questions. I would request each one of you to make sure that you remain muted during the conversation. Send your questions on the chat box so that others who are listening will also benefit from your questions, and this will avoid a lot of repetitive questions. So let me begin by introducing Dr. Mukul Verma, a senior consultant neurologist at the Indraprastha Apollo Hospital since 1996. He obtained his DM in neurology from the prestigious King George's Medical College in Lucknow. He has a special interest in movement disorders and has been initiated the deep brain stimulation program for advanced Parkinson's disease at the Indraprastha Hospital. He has been a participant and has been a principal investigator in several clinical trials associated with Parkinson's disease and has quite a few publications in those areas. He is a member of several international neurological societies. In addition to these professional qualifications, this man is an interesting parallel life, which includes he is an excellent bird photographer, the proper birds I'm talking about. He's interested in trekking and rafting in the Himalayas. He's a qualified scuba diver. Did you hear me say driver? I meant diver. So just a slip of the tongue. So I think before I bring him on, the greatest quality for Mukul Verma, let me tell you, he's an amazingly committed doctor, very passionate, very caring for his patient, and a great friend. So can I introduce Mukul? Mukul, would you like to take over?
Thank you, Dr. Subra, so for those kind words. So I am just going to speak for about 15 minutes about some signs and symptoms and certain basic things about Parkinsonism and Parkinson's disease, and then I'll hand over to Dr. Prabhat Ranjan, who's going to talk. His the main talk today, and so I'll be kind of an introductory thing for just telling you some of the signs and symptoms.
Sorry, Mukul, can I be rude for a moment and interrupt you? Just to remind all our participants what Dr. Mukul Verma mentioned earlier, in the interest of the patient confidentiality, please do not record any of the videos that he will be showing, because this is very, very important. We as treating doctors respect patient confidentiality immensely. Thank you.
Thank you. That was the right thing, because we don't want any people coming back to us and saying that. So I'm just going to share my screen now, and I'm going to start my presentation. Is my screen being shared?
Yes.
Right. So I'm going to talk about Parkinson's disease, some basics. There's not enough time to cover too much, but I'll try to kind of keep it as simple and as sweet as possible. So you know that Parkinson's disease is a dysfunction of the basal ganglia, which are basically the striatum, the pallidum, and the subthalamic nucleus, and the substantia nigra. And that is called nigra because of its dark coloration, which you can see here. And this is the place where the dopamine producing neurons are in the brain. The function of the basal ganglia is to receive information from the cortex, process it, and send it back to the cortex, and for things to be done. Now, this is done through several corticostriato-thalamocortical loops, and the premotor loop is concerned with mainly the spontaneous movements, the initiation of spontaneous non-stimuli movements, automatic movements. For example, if you have once learned how to drive a car, then you don't need to think about how you're driving. You can be talking on a phone, you could be talking to somebody else, and still you're driving. So these are automatic movements, and these are being covered by the basal ganglia and postural reflexes. But movements are not the only thing. They also, through the orbitofrontal loop, they regulate social behavior, your state of inhibition, your state of disinhibition. And through the lateral prefrontal loop, they control executive function, planning, and working memory. Parkinsonism is a syndrome in which you have four features mainly. The fundamental feature is akinesia, which basically means a paucity of movement. And this could be hypokinesia, which means less movement. It could be bradykinesia, which means slowing of movement. And this is a fundamental feature. And if somebody has tremor but does not have akinesia, then he is not a patient of Parkinsonism. The next is rigidity, and this is a lead pipe kind of rigidity. And sometimes when it is superimposed with tremor, we call it a cogwheeling rigidity. Then you have postural and gait disturbances, which I will discuss in the next few slides. The cause of Parkinsonism, as the commonest, are the degenerative causes, amongst which Parkinson's disease is the commonest, and this forms about 30%, more than 30% of all the patients visiting a movement disorder clinic. Then, and this is called Parkinson's disease. So Parkinson's disease is actually a form of Parkinsonism, and the two are not the same. So Parkinson's disease is the commonest. This is a degenerative condition. Then you have other degenerative conditions which are called atypical Parkinsonism, and they are listed here: PSP, corticobasal degeneration, MSA, Lewy body dementia. And then Parkinsonism can be drug-induced, which is commonly seen with antipsychotics and certain antiemetics. And nowadays, levosulpiride is also commonly seen to cause Parkinsonism in elderly people. And any disease which causes damage to the basal ganglia can result in Parkinsonism. So in Parkinson's disease, which is the degenerative variety, which is a slowly progressive incurable illness, the theory behind the etiology is that some environmental toxin or some genetic factors, they cause an alteration of an intracellular protein called alpha-synuclein protein. And this altered protein becomes toxic to the cells and then starts to destroy the neurons. So this is stored in form of Lewy bodies within the neurons. But after some time, this aggregation of the Lewy bodies is overwhelmed, and the toxicity of the protein destroys the cell, causing a neuronal death. And this kind of thing is seen in the olfactory bulbs. So loss of smell is a very early feature of Parkinson's disease. It is seen in the brainstem, and then from there it ascends upwards into the substantia nigra and into the cortex. And this is the cross section of a patient of Parkinson's, where you can see that the substantia nigra is much less pigmented. The epidemiology, it affects mainly elderly people, and the mean age of onset is 60, and 1 in 200 individuals above the age of 80 will get Parkinson's disease. And rarely 5% of cases have a young onset. There is a negative association with coffee drinking and smoking. And if somebody in a first degree relative has Parkinson's, then you have a 2.5 times the risk of developing it. And there is a weak association found with pesticide exposure. So the symptoms and the signs are elicited by a few videos which I'll show. This is a patient. You can see the masking of his facial expression. This is called hypomimia. And you can see that his rapid alternating movements are very erratic and slow. He's unable to get up from the stool and needs assistance to do that. So there is a severe bradykinesia in this patient. There is not too much tremor, and there are certain varieties of Parkinsonism which have more tremor, and certain varieties which have more posture and gait instability. So this is the posture and gait instability variety. You can see that he has a shuffling gait, he has a stoop posture. And when this gets more advanced, then the stooping is more. You can see this is a tremor, and he is demonstrating something called propulsion, where they start going very fast and can fall. Now, the cardinal symptom, which I already told you, is bradykinesia and not tremor. In this patient, you can see there is an asymmetry of tremor, of bradykinesia. It's on the right side. You can see that. And asymmetry is a feature of the typical variety of Parkinson's disease. And why I wanted to show is that in this other patient, there is no bradykinesia. He has tremor, but his tremor is a cerebellar tremor, and it doesn't have any bradykinesia. You can see he's able to move with speed. Only thing is that he has loss of control over his movement. So he's not a patient of Parkinson's disease. He's a patient of spinocerebellar ataxia. Another patient showing the tremor, which is typically a rest tremor, which you can elicit by distracting the patient. And you can see that this is more on the right side. The moment the patient starts to use his hand, the tremor will stop. You see, now it stops, and then it re-emerges, and that's called a emergent tremor. So Parkinsonian tremor is a rest tremor which stops on movement, then re-emerges, and this is how you can differentiate it from different varieties of tremor. Which now here is a patient of action tremor. The tremor comes when the patient is using his hand, and whereas it was not there on rest. And this is a patient of essential tremor. So this patient is not a patient of Parkinson's disease. Another thing which we see is called freezing, where the patient gets up and the feet get frozen to the ground. He is trying to walk, but they're kind of like frozen. It's also called magnetic gait. And this is seen most when the gait is being initiated, and when the patient turns, that's when it happens more. And another thing that one can demonstrate is the pull test, which shows loss of postural stability, and the patient tends to fall when you pull a patient. Normally, the patient would regain his posture. In atypical Parkinsonism, the things are much more rapid, and there are certain signs which one can see. And in this patient, you are seeing a wide-eyed look and supranuclear gaze palsy. The patient is not able to look up and down when the patient is being instructed to do so. And you see a wide-eyed look. This is a patient of progressive supranuclear palsy. And in the other patient, you see So the speech is very fast, and this is called tachyphemia, and this is seen in a patient of PSP. All these features can appear in much later in Parkinson's disease also, but usually after 10 years or so. But in atypical Parkinson's, these features, they begin with these features. Uh, in Parkinson's disease, the MRI is usually normal, but in atypical, you can see different varieties of signs. This is known as the hot cross bun. You can see a hot cross bun here in the medulla. In MSA, in cerebellar atrophy, you can see in spinocerebellar degeneration. And hummingbird sign, you see a beak-like hummingbird in PSP. And loss of postural reflexes are even much more worse in patients of atypical Parkinsonism, especially PSP patients. But Parkinsonism can be drug induced also, and this is easy to treat. As you can see in this patient, she was taking antipsychotics, which caused features of Parkinsonism. You can see the poor arm swing, the tremor, all of those things are there. And then after stopping those medications, the patient has improved. You can see she's much better. But apart from motor symptoms, there are lots of non-motor features in Parkinson's disease, and they can be divided into 4 categories. The first is a neuropsychiatric dysfunction. About 1/3 of patients will get depression, mood disorders, anxiety, cognitive dysfunction, dementia. They get psychosis and impulse control disorders and other compulsive behaviors. Many of them will get autonomic dysfunction like orthostatic hypotension, urinary dysfunction, sexual dysfunction, sweating, drooling of saliva. Then disorders of sleep and wakefulness are very common. There is a lot of sleep fragmentation and insomnia in these patients. They can get REM, sleep behavior disorders, in which they thrash around and scream during sleeping. And they can also get daytime sleepiness and sudden onset of sleep in the day. And some patients will get sensory symptoms like pain, loss of smell, which I already spoken about. And one needs to see the whole picture in these patients, because non-motor symptoms adversely affect the quality of life. They are frequently not declared by the patient, and maybe even medication induced. So you may have to change the medication, and they may even precede the motor symptoms even before the motor symptoms appear. So you have to have a look out for the non-motor symptoms. As you can see, this is a scarlet minivet, and we can miss its spouse, which is always with this bird. Whenever you see a scarlet minivet, you see the spouse nearby. So you have to ask for these non-motor symptoms. Then you know that levodopa is one of the mainstays of treatment, medical treatment of Parkinson's. In Parkinson's disease, they develop something called the motor fluctuation stage, the on and off phenomena. And so when the patient, the effect of the medicine wears off very quickly, and they go back to hypokinesia, bradykinesia, and the moment you give medicine, then they start having dyskinesias. And as you can see in this patient, he has levodopa induced dyskinesias, which are coriform movements. And dyskinesias can be peak dose, they can be end of dose, and they can be biphasic. There's not enough time to go into that, but there are ways to manage all these conditions. What about neurosurgical treatment? As you know, that in Parkinson's disease, because of the dopamine being reduced from the nigra compacta, substantia nigra, there is a hyperactivity of the GPI and the subthalamic nucleus. So if you put a lesion in the GPI, you can actually reverse the signs of the motor symptoms of Parkinson. And if you put a lesion in the subthalamic nucleus, that has even a better effect. So there is something called deep brain stimulation, where you put.
No, I'm unmuted. Mukul, can I interrupt you, Mukul? We have lost your voice. Just type in the chat that we can't hear. Sorry, we lost your voice, Mukul.
So kindly check the attachment of your headphone.
Can you hear?
That's better. Thanks. Yeah.
Okay,
Great.
okay. Sorry, so can you hear me now?
Yes, sir.
Okay. So in deep brain stimulation, we put an electrode in the subthalamic nucleus or the GPI, and that a high frequency stimulation causes an inhibition of the target nucleus, and thereby we inhibit the overacting nucleus and cause advantages. But this is an advantage over lesioning the lesion, the nucleus, because this can be undone, it can be adjusted and programmed, and programming is very important. It can be done on both the sides and leaves intact brain tissue for future modalities. So this is a patient of mine who we did deep brain stimulation very recently. My colleague Dr. Sudhir Tyagi performed the operation and I did the programming. You can see he's a very advanced Parkinson's disease. He can barely walk. Sorry. And he needs assistance to get up. He's got severe bradykinesia. And then after the deep brain stimulation, this is his son sent me his video. So he's done really well. And deep brain stimulation is a boon for many patients. Only thing is it's rather expensive, costs about 15 lakhs, and not everybody can afford it. So in Parkinson's management, this is my last slide, a multidisciplinary treatment is needed. And you need a neurologist, psychiatrist, geriatrician, a urologist, you need counselors and a neurosurgeon. But most important, you need a physiotherapist and a neurophysiotherapist. So I won't come between you and Dr. Prabhat Ranjan, who is going to talk to you about recent advances in neurophysiotherapy for patients of Parkinson's disease. Thank you very much.
Thank you, Dr. Mukul Verma. I think that was a wonderful overview of what Parkinson's is about, and very useful for many of us who probably would not have understood the deeper part of the neurology of it. And it was really very heartening and very fascinating to see the response to the deep brain stimulation on this particular gentleman. And I'm sure there'll be many who would benefit from this kind of treatment. While many of us are dying to ask you a lot of questions, I think we'll probably bring in Dr. Prabhat Ranjan at this point in time, as you've highlighted the value of the physical therapy in restoring normalcy to these people. We are really very pleased to have with us Dr. Prabhat Ranjan, who is currently working as a senior physiotherapist in the Department of Neurology at the prestigious All India Institute of Medical Sciences for over the last 2 decades. He's a member of the Delhi Council for Physio and Occupational Therapy, an executive member of the National Indian Association of Physiotherapists. He has been a visiting faculty to several colleges for a long time, an examiner to several universities, has organized 6 international conferences on physical therapy at the All India Institute of Medical Sciences. So I think you're all waiting to listen to the expertise of Dr. Prabhat Ranjan. Dr. Prabhat.
Thank you, sir. Thank you, Dr. Mukul Verma. You had a very nice presentation. I think you have covered that part of the main basic pathology and etiology of the Parkinsonism. So I will be cut shorting that part, and Mostly I will be concentrating on the physiotherapy part and what are the stages and what are the testing tools for the functional outcome of the Parkinsonism patient. So I'll just screen. Some technical problems. So now it's clear, sir?
Yes.
Yeah. Thank you. So I will also talk about the artificial intelligence, that how it can impact the functional outcome of a Parkinsonism patient. So I will skip these parts as it has been discussed already by Dr. Mukul Verma, that what is Parkinson's disease, as there is shaking, stiffness, difficulty in walking, and it is a disease of elderly. The cardinal signs, these has been discussed by him. There are stages of the Parkinson and it has been divided into 5 parts. Number 1 stage is that as Dr. Mukul was showing the video of a patient having a resting tremor and then the functional tremor, in that if the person is able to perform the task very uh, smoothly, but there is some difficulty, but smoothly he can perform the task, then that patient can be considered in stage 1. He can walk nicely, he can have the facial expression. There may be little difficulty, but though also he will be able to perform the task. That was stage 1. In stage 2, he may need some that bradykinesia, that slowness of movement increases. The time which earlier he was taking the to perform the task was around 10 to 15 seconds. Now he will take around 20 to 30 seconds. So when the time increases, the symptoms little bit get worsen up, then we can say that the subject has achieved the stage 2 part. In stage 3, he will have that movement, but he will need some assistance. He will have this more apparent slowness. The slowness will be apparent. He will have a frequent fall, and he can still live independently, but he will need some assistance while doing some activity which is related to that smaller activity like dressing, like combing, like eating. He will need little bit of assistance in performing those activities. In stage 4, patient needs lot of assistance, either for walking, either for performing any task, and he is not able to live independently, where he doesn't need where he needs some assistance and he is not able to live the life independently, his quality of life is decreased, then we can say that this is stage 4 of the Parkinson's disease. And this is stage 4. And then stage 5 is a bit challenging for a physiotherapist also in order to get the functional outcome, because that bradykinesia, slowness of movement, tremors and all that are very evident. And in that condition, as Dr. Mukul Verma has shown about the DBS part, that DBS helps a lot. And when it is properly you can say that when proper doses and everything is set, and with the help of the physiotherapy, we can achieve some of the functional outcome in those subjects. In stage 5, mostly the patients are bedridden and he will require some type of nursing. He will always, for anything, he will require the help or the assistance, and he will not be able to perform any of the activity independently. That we can say that it is stage 4. Non-motor functions has been described by Dr. Mukul. So now I will come to the one of the scale which is very much important in Parkinson's disease in calculating the functional outcome of the subject, and it is known as Unified Parkinson's Disease Rating Scale. This scale is having a very large amount of functional activity, where from the mental level, cognitive level, from the ADL, everything has been planned out in a very systemic manner, and the overall score is 199. And if one is able to achieve that 199, then we can say that the subject is having good functional outcome. But if it is decreasing and it is below 60, then we can say that the subject is having a poor quality of life, and he will need some assistance in leading some good quality of life. And there are 4 scores in that. One score that one, suppose we take the mental aspect, we will ask him the memory, about memory, and if he is able to answer that memory very properly, then you can say that the subject is having normal UPDRS score in terms of mental. And if he is having some difficulty in reminding that thing, or there's some slowness, then you can grade 2. If he takes much time, if he needs some type of hint or tip to memorize those things, then you can grade that score as 2 in mental aspect. In 3, even if you are giving some clues or anything, and hesitation, the awkward look is there, there is staring is there, is not able to memorize the thing. And then later on, after an hour, or you can say that he initiates something, that memory is initiated, then you can grade 3. And when he is not able to recognize the things in a mental aspect, then 4 can be graded, such that this is for the functional outcome also. So any task has to be performed, and if the task is performed nicely, then 0 you can grade. Time is taken, suppose the 10-second time is taken, then 1 grade can be given. More time is taken and some difficulty is there, then grade 2 may be there. Another performance is being given to the subject, some task is given, he takes some assistance and slowly and gradually is able to do the function, then grade 3. And where he cannot perform any task, then grade 4 in terms of the task. So for gate also, for everything, there is one activity, daily living, speech also, salivation also, depression also, all this can be calculated through this Unified Parkinson Disease Rating Scale. So this I will skip these things, devious part. So for physiotherapy, when it comes to the rehabilitation, as Dr. Mukul was telling, that it is one of the most important part in his last slide, that physiotherapy is most important to gain the functional outcome in the subject. And physiotherapy helps in the mobility, flexibility, strength, gait speed, aerobic capacity, and above all, this helps in leading good quality of life, because quality of life is decreased in this patient due to the slowness of movement, due to the rigidity, due to stiffness in the joints. So we have to maintain this quality of life through these exercises. Mobility exercises can be given, flexibility exercises can be given, strength has to be increased, gait has to be properly addressed, and aerobic capacity for the, because what happens that the posture is stooped, the muscles, the breathing muscles, diaphragmatic muscles, and the chest expansion is low, then what happens that vital capacity also decreases in those subjects, and we have to maintain that vital capacity. For that, aerobic exercises and breathing exercises should be also be focused for the good quality of life. So nowadays, I will show the video of the exercises as I finish this talk. Then I will show the videos that how to gain the mobility, the strength, and the stretching. Then we can have the later on that we can have later on. Now I will talk of the artificial intelligence. What is artificial intelligence? Now the things are coming up, computer sciences. See, earlier we used to have the classes on board classes, in board classes, but now today we are in this era of pandemic, as Dr. Subramaniam was also telling, that in this era of pandemic, we are connecting virtually, and then virtual education is going on. So this is this sort of things are like artificial intelligence. And this artificial intelligence in terms of treating the subject of Parkinsonism will become significant in the coming days, especially in India. Now it's not there so much significant, but it may come in the coming days. And abroad, it is being practiced now easily in a wide spread manner, but India, it will take time. And I think that we should be prepared for that, that how it helps in maximizing the goal or optimizing the functional outcome of any subject. Because this artificial intelligence, through their sensors and all that, they interpret the data, they help in learning and adapting the flexibility of the function so that a specific goal or a specific task can be performed. So for that, for how to test the efficacy, for the testing of the efficacy, there are some tests like we can go through the UPDRS scale. First, we can pre-treatment, post-treatment. We can see the UPDRS scale, time up and go test, Berg balance test. These tests can be performed pre and post, and thus we can say that how much artificial intelligence has impacted in getting the functional outcome of a Parkinson's patient. So what happens that when this is a view, you can see that there are this is a chamber where harness is there, and if the patient's stability is not proper, initially the harness is applied, and as per the harness, he goes to that virtual world where there is all sorts of that software is placed, and he will have the odd and even surfaces where he will feel that he is walking on those surfaces, and slowly and gradually he will gain that balance, as Dr. Mukul was also telling, that if one is driving the car and later on he doesn't need to have that type of practice, he works on, then that principle works in this, and he is working on that. The working is done on that, and then such type of pathway is created that the subject starts doing on his own, and this helps in getting his better functional outcome. This I will show you through a video here. The video is visible.
Williams is buckled up and ready for action. It looks and feels like she's part of a video game, but it's actually high-tech rehab for her Parkinson's disease.
The video is not visible.
You have to challenge patients for them to get better. And so this provides a very safe environment for that to occur.
So you are not able to see the video?
They're not.
Okay. Is it visible now, sir?
Sandy Williams is buckled up.
No, we can hear the sound, but we can't see the image at all.
Actually, high-tech rehab for her Parkinson's disease. Sandy Williams is buckled up and ready for action. It looks and feels like she's part of a video game.
Okay. It's still not visible.
For her Parkinson's disease.
We know in neurorehabilitation.
Yeah, no, that's what you need to do. Yeah, I think he's probably kicking at a different area earlier.
Sandy Williams is buckled up and ready for action. It looks and feels like she's part of a video game, but it's actually high-tech rehab for her Parkinson's disease.
Visible, sir?
Sorry, Dr. Ranjan.
Yeah.
I think it's still not visible. And can I use this opportunity to remind everybody to remain on mute, please? Thank you.
Sandy Williams is buckled up and ready for action. It looks and feels like she's part of a video game.
Dr. Ranjan, again.
Rehab.
Yes, sir.
We're not getting the video, sir.
Neurorehabilitation, you have to challenge patients for them to get.
Would you like to put this on a PPT mode? On a play mode, it'll probably be okay.
Yes, sir. I'm checking it.
Yeah. Yeah, just put it on a slideshow. I think it should be okay. Okay.
Sandy Williams is buckled up and ready for action. It looks and feels like she's part of a video game, but it's actually high-tech rehab for her Parkinson's disease.
We know in neurorehabilitation, you have to challenge patients for them to get better. And so this provides a very safe environment for that to occur.
The video is not visible yet, sir.
No, it's not, sir. It's not happening. Maybe you could just go back to your presentation.
Yeah.
And go to the slideshow.
Sandy Williams is buckled up and ready for action. It looks and feels like she's part of a video game, but it's actually high-tech rehab for her Parkinson's disease.
We know in neurorehabilitation, you have to challenge patients for them to get better. And so this provides a very safe environment for that to occur.
The virtual reality treadmill has 2 belts, one for each foot, and a base that moves to mimic different surfaces.
Yeah, I think continue with your presentation. Maybe we'll skip the video, not to worry about that.
Sir, just I will explain what the video was about. This video was about the gait training, that how the harness was done, and first the simple task was being performed and the subject was able to walk, and then we went to the dual task performance, because dual task performance is a little bit tough in cases of Parkinsonism, and with that cognitive level also is sometimes impaired. So these tasks has been given to the subject and he was able to perform, and later on without harness he was able to perform those tasks. So slowly and gradually he developed the skill, and his functional outcome improved and he was walking.
Dr. Ranjan, could you speak a little louder, sir?
Hello, can you hear me, sir, now?
I can hear you. I mean, there are some of them who can't hear you very well. Perhaps a little louder, please.
So how it is happening, because as Dr. Mukul also said that the brain is plastic, and that neuroplasticity is also working in this concept, and this neuroplasticity is helping in subject in getting the proper functional outcome. So the other video was there, that how these sensors work, that magnetometer is there, accelerometer is there, and gyrometer is there, and how these works was the video that I'll see that it plays, or when it will play then it will be good.
The more I exercise, the better I feel.
Like most Parkinson's disease patients, exercise eases Mary Spletter's tremors, halted gait.
Dr. Ranjan, can I interrupt?
Yes, sir. Sure, sir.
Yeah, I think the video is not playing. Maybe we could just move on so that, we could take the questions and things.
Yes.
Let's skip the videos for the time being. It's not working. Yeah.
Sir, I have the video for my exercises also, so that if things work.
That's right. That's right. It's not happening. It's not happening. Anurag Srivastav says. Dr. Ranjan, can you hear me?
Yes, sir.
One of the options suggested is start your video and then share the screen.
Start my video and
go off share screen.
So that won't work. Sorry for the interruption. The video is not playing on PowerPoint.
Yeah.
Since it's not playing on PowerPoint, it won't matter much.
Okay,
the only option is like we did yesterday. We can play the video on the media player instead of PowerPoint.
You can try and do that. Yeah.
This is visible, sir?
Hello, I am Prabhat Ranjan and I'm a neurophysiotherapist.
Yep.
I am here to explain about some of the strengthening exercises for the Parkinson's patient. Because it has been observed that as the time goes or you grow older, the muscle strength lowers down. And especially in the cases where there is some disease, then it has been observed that it is much weaker. Hello, I am Prabhat Ranjan.
So now it's fine. So you can let it play if
video is playing, sir.
Yes, sir. Now it was fine. You can let it play.
Yeah.
The first time you played it, it was playing.
Okay.
The first time you played your exercise introduction video.
Yeah, the starting was okay. Yeah.
Yeah.
This is
and
playing.
It stopped all of a sudden. Yeah.
Hello, I am Prabhat Ranjan.
No, now it's not playing.
Therapist. I am here to explain about some of the strengthening exercises for the Parkinson's patient.
It's not. The video is not playing.
As the time.
First time it was playing.
Yeah.
The first time you played it, it played, but then you stopped it and then you replayed it, then it wasn't.
Again, sir, I will try it.
Yes, now it's playing.
Hello, I am Prabhat Ranjan and I'm a neurophysiotherapist. I am here to explain about some of the strengthening exercises for the Parkinson's patient. Observe that as the time goes or you grow older, the muscle strength lowers down. And especially in the cases where there is some disease, then it has been observed.
It is fine. It is fine now. It is good.
Weaker than the people of similar age with no any other neurological problem. In Parkinson's also, this happens, and the subject who is suffering from Parkinson's are having a weaker muscle in comparison to the other individual who are not having any neurological disorder. So we can go for this training program. For that, some points has to be taken care. One is that there should be a suitable environment. For that, we have to make sure that proper support is there so that one should not fall. The symptoms should be well within the control. Suppose if the subject is having on phase, then he will be able to do the exercises properly, but as soon as he goes into the off phase, then he will have some problem. The exercises should be done 3 times a week. Take a rest in between a day. One day you do the exercises, the other day you take a rest, so that the muscle doesn't become so much of fatigue. One thing or more is important, that exercises should be done at any individual of Parkinson, that the pace should not be much higher or much lower. Whatever pace he is having or he is generating himself, at that pace only the exercises should be done. So now I will demonstrate what are the simple exercises for the strengthening of the muscle. So take a chair. The chair should be firm on the ground, and make sure that it doesn't slip while getting up. Initially try to have the chair with the armrest, so that the subject who is suffering from Parkinson's can take the support of bilateral armrest in order to get up. This exercise should be performed 10 times at a time, and you can make a set of 10 repetitions. 10 set, then take a rest, then 10 set, then take a rest, and then 10 set. So we can do it in this way. Take the support of the armrest. With the support of the armrest, the subject will get up, and then again he can flex his back and then sit down. Like this, he has to perform 10 repetitions, and slowly and gradually, as the time overcomes and he is feeling confident, the subject, then he can stand up without the armrest, help of the armrest, and then sit without taking the help of the armrest. In this, we can adjust the height of the chair, where we can start from the comfort level of the subject. If we have to make the height of the chair higher for his comfort level in order to perform the sit to stand exercise, then keep the level of the chair higher. Slowly and gradually we can lower the level of the chair in order to build the muscles of the lower leg. This may help in developing the balance of the subject. So for that, take the support of the chair. The chair should be firm on the ground, it should not slip. Stand upright, look in front, take the support of the chair, and then go on your heel, and then slowly come down. Do it for the 10 repetitions, then down, 10 repetitions, then down, then take a rest, again 10 repetitions, then take a rest, then again 10 repetitions. This will help in developing the muscle of the calf, as well as also help in getting the balance movement while walking. It's standing, and that is lateral step up. So keep one of your leg on the stepper, and then with the help of your muscle power, the body weight, just get up, hold, and then come down. Then hold, come down. This also 10 repetitions. Wait for some time, then 10 repetitions, take a rest, and then 10 repetitions. If you are not able to do this exercise independently, as there are some stages in the Parkinson, stage 1, stage 2, stage 3. So stage 2 or 3 sometimes may need some support. So keep a chair by your side, or you can take the support of the wall, stand against the wall laterally, and then put the one leg on the stepper, and then with the help of the support you can do this movement. This will help in gaining the strength of your quadriceps muscle, as well as your calf muscles as well as your front foot muscles. So this will help you in gaining the balance also. Exercise is sliding down, or you can say the half squat. Take the support of the wall, put the leg little bit front, and then the help of a body which is upright and is touching the wall, just slide down, and it should be as such that it should not cross over your toe, greater toe. It should be near the toe or about at the parallel to the toe. It should not be in front of the toe. So get down, then up. If any problem in doing independently, you can take support of the wall, stand like this in the wall, and then go up and then go down, then go up, then go down. This also 10 repetitions, take rest, then 10 repetition, take rest, then 10 repetitions. Band, the middle of the TheraBand doesn't get squeezed. Make sure that it is not squeezed, and wrap in your hand, put it in such a fashion that attention is developed in between. Attention is developed. So now I think that the tension has been developed. Take the flatter part and then put it in the middle of your both leg, and the tension is developed. So keep your arms straight, sit upright, and then flex your elbow. In the meantime, try to squeeze your blades, scapular blade, and then open up the chest. This time, we can do it 10 repetitions to strengthen the upper muscles. Like this from the back, and the scapula will squeeze, both the scapular blade will come together, and the chest will open up. We also done for the deltoid strengthening. Put the TheraBand in the middle so that it should not slip. Put your hand straight, slip, and then slowly take up to the 90 degree straight, and then down, then other hand straight, then down, then other hand straight and down. It should be done 10 repetitions, but if you are any of the subject is not able to complete the repetition of the 10, then 5 sets also can be done. Then further we can proceed bilaterally also. Put the TheraBand underneath your foot, stable, and then bilaterally we can proceed. Then we can also do it for the elbow. Tighten the TheraBand and then up and down. Flex your elbow, straighten up, flex your elbow, straighten up, flex your elbow, straighten up. Same this way, flex your elbow, straighten up, flex your elbow, straighten up. This can be done 10 repetitions. If not able to perform, then make a set of 5 also, so that slowly and gradually the subject can progress for the 30 repetitions per 10 seconds.
Start.
So now for the strengthening of the lower limb, suppose you want to strengthen the muscles of the lower limb of the right side, and how we can put the TheraBand, we should tie it over the leg which we want to strengthen in such a manner that it should not slip. Then the other end should be at your other leg. Put it in the middle in such a way that attention is developed here. So put it here. You can either you can hold with your hand, or you can just put it underneath the chair, hold it firmly with this leg, and then lift up and down, lift up and down, lift up then down. 10 repetitions this leg, then the 10 repetitions after time the same manner with this leg, and in that set you can do it for 30 repetitions in a set of 10.
Cool.
Then this exercise can be done in standing position also. We can take a hard chair so that we have to see that it should not slip. Otherwise, on a bar, any bar is there, we can tie this, just this is for the demonstration. I will show you that we can tie it underneath the chair, one end, and the other end should be tied at the leg which we want to strengthen it in such a fashion that the tension is developed here, and then we will tie it so just this way, then out. Then we can do it in this manner also. We can stand in front of the chair, take it back, front, back, hold it, then front, and we have to stand upright, back, then back and up. This can be done for both the legs, one by one, 10 repetitions, take rest, 10 repetitions, take rest, then 10 repetitions. So when you go through the bands, there are several types of band. This is the moderate one. We can start with the low resistance band also. The red one is the low resistance, and the yellow one is one of the very low resistance. This yellow one is having very low resistance. Then heavy resistance is the blue, and the black one I am not having, but blue I am having. The blue and black one, as per the requirement of the subject, we can introduce the therabands, and this theraband exercise is very good in strengthening, and especially in the subject who are in stage 2 or stage 3 of the Parkinson's disease. There it can be helpful. Stage 1 it is very much helpful, so we can try these theraband exercises also, but please take care that this patient is stable, the object which we are using is stable, there is no chance of falling, and environment should be very much cordial for the subject. Apart from strengthening, we can go for stretching also, and stretching of the trunk is very important because this becomes stiff, and as this posture is stooped, then this restricts the movement. So we can do this stretching. A very simple stretching exercise is there. We can lie on the mat. We should lie on the mat. Flex both the knees. We have to flex both the knees. And when we are rotating the lower limb towards the left side, our neck should go towards the right side. Then again, if it is going to the right side, the neck should go to the left side. This way we can stretch. Other way, we can put the hand underneath the head. Second step, we can do that. This will stretch the pectorals as well, and then we can stretch the lower limb, and then we can take the head to the opposite side. If we are taking the limb to the right side, then the head should go to the left side, and we should make sure that our scapula as well as the elbow is not lifting up, and it is stick to the ground as much as it is possible. There are many other exercises. These were the simple exercises which can be performed with standing and the stretching. Then lot of exercises regarding to balance is there, and for that specific those exercises we should consult our physiotherapist or the treating doctor so that he can refer to the proper neurophysiotherapist. So neurophysiotherapists are much more oriented about these exercises, and they will guide you well. Thank you very much.
So, can I play the other video also? If it is visible, because last time it was not.
Dr. Ranjan, that video came out very well.
This one is coming up.
Sandy Williams is buckled up and ready for action. It looks and feels like she's part of a video game, but it's actually high.
This video is about the harness.
Sandy Williams is buckled up and ready for action. It looks and feels like she's part of a video game, but it's actually high-tech rehab for her Parkinson's disease.
We know in neurorehabilitation, you have to challenge patients for them to get better. And so this provides a very safe environment for that to occur.
The virtual reality treadmill has 2 belts, one for each foot, and a base that moves to mimic different surfaces. It can also react and adjust to a patient's movement, and a wraparound video screen completely immerses the patient into a real-life scenario.
When I go over like a little hill, you feel it in the machine.
Rather than just having the patient walk or an individual walk up and down a standard biomechanical track, now what we can do is we can change the environment in a very dynamic fashion.
Special programs are designed to work on specific skill sets while providing positive feedback. During weekly appointments at Cleveland Clinic, Sandy works with her therapist on gait and increasing stride length by touching her toe to a box. Other times, she's asked to target birds and butterflies while walking. This helps with balance, and it satisfies that competitive spirit.
I enjoy doing the birds and the butterflies and swatting them down and killing them. Not that I enjoy the killing part, but I do enjoy the challenge of, can I get them? I know once I slow down, it could come to the point where I couldn't move. So I'm willing to do whatever I can to keep myself going.
At Cleveland Clinic, I'm Erica Foreman.
So here we saw that how she became independent later on. First she was doing a single task, then hitting was there. That was the dual task also she was performing. So from simpler to complex task we can go for the subject, and this complex task, if he or she is able to perform, then he may have a good functional outcome. This video I am again showing, this is the how the virtual reality works. What are the sensors which do help in getting the accurate sense and data collection in
Even it works, it's okay, I suppose. Yeah.
The more I exercise, the better I feel.
Like most Parkinson's disease patients, exercise eases Mary Spletter's tremors, halted gait, and lack of balance. She recently took part in a UCSF study to see if special video games could replace her regular exercises.
Let's go.
The therapeutic games are the result of a marriage between game developers and scientific researchers.
Well, UCSF had developed a series of exercise programs for patients with Parkinson's. And they asked us if we could actually make a video of it. And we said, there's this new thing called the Wii. Why don't we make interactive games?
UCSF researchers thought video games might be a welcome change of pace from physical therapy, which can be tedious.
People very much like doing the games. They found them engaging, fun, and therapeutic.
But developing games that would know if patients were using the right muscles in the right way was tricky. Health games need to detect a player's movements much more precisely than their consumer counterparts.
So there's 3 different devices that you need to be able to sense where you are in a particular space. One is an accelerometer. Am I moving a particular direction? Another one is a gyroscope, which is which direction am I pointing? And then third, you need something like to say, okay, I need a rock solid north, and that's a magnetometer.
These 3 technologies enable smart devices to do this. To make the technology more accurate, the developers created suits with 9 built-in sensors.
They were a big pain.
The battery-operated suits were awkward and cumbersome, so the developers turned to camera technology.
It's bathing you in infrared light and then taking that information and using some very clever software to say, you just raised your hand.
The camera technology does not need to be worn, but it's not as accurate as the sensors.
Each one has their pluses and minuses, and we're looking at actually trying to perform a fusion between those 2 technologies.
The UCSF study showed that despite their physical limitations, Parkinson's patients could successfully play the games at home. And they did them more often because they enjoyed them and they helped.
Yeah, I'm tired. It was a fun way and an easy way to exercise right in my own front room at any time. I felt better. I felt more normal, more fluid, looser.
In fact, the study found that after playing the games for 12 weeks, 65% of patients had longer strides, 55% had increased gait velocity, and 55% also reported improved balance.
The hope is that if we can engage people in physical activity early in the disease course, that we might actually be able to delay progression. There.
The therapeutic games could be available to the public as early as next fall. For Smart Planet, I'm Sumi Das.
So here we saw that how this works with the accelerometer, gyrometer, and manometer, and these sensor helps in getting the movement elicited, and then proper data can be collected and helps in getting the functional outcome also, as you saw that balance and all that, the rotation of the spine, the trunk was done through the gaming process, and it actually you can say that it was like a biofeedback system. So this is helping, and I think later on these type of technology will be much more in getting the functional outcome in the Parkinson's patient. So this was all about my presentation, and nowadays some type of other equipments are also there, like we can have these equipments will help in having the accurate data of the tremors or the slowness of the movement. So these type of equipments are coming up. These will help us in getting walking at set how much cadence or the slow and movement or the time he took. This is for the hand tremor. This will count that how much tremors he is having, he or she is having in 1 minute or 2 minutes. Then later on pre-exercises, post-exercises, how much it reduced. So these type of things will help the us in getting more accurate research and more concise treatment to the subject who is suffering from the Parkinson's disease. Thank you. And in coming years, the advancement of technology measuring of Parkinson's rehabilitation will grow significantly for the better outcome and good quality of life. Thank you.
Thank you, Dr. Ranjan. I'm sure if this was a normal kind of a live meeting, most people would have stood up and given you a big round of applause. I think tremendous work, very well presented.
Thank you, sir.
I'm sure that, following that very lucid presentation by Dr. Mukul Varma on the basic outlines on Parkinson's and its management, we've had a tremendous presentation on various dimensions of getting the best out of Parkinson's treatment. The role of the simple exercises was so beautifully displayed by Dr. Ranjan. The role of partnerships, the partnerships between the game developers and the researchers at the University of California. Playing games, which you and I would have thought that people with physical disabilities may not be able to do. But you realize that the playing games was actually helping people develop excellent skills, improving their strides, developing the confidence, etc. He demonstrated the robotic walker to begin with. He spoke about the role of the wearables in reducing the tremors, and measuring so many other parameters. So I think this has been a tremendous range of subjects that we have covered on Parkinson's today. So maybe it's time for us to now go on to a few questions which had come our way. So can I just begin by addressing the first question to Dr. Mukul Varma. Mukul, would you tell us about how does one treat a patient with severe on and off phenomena in Parkinson's disease?
That's a very good question, Dr. Subra. As you know, in advanced Parkinson's, there are two phenomena which occur. One is that the medicine levodopa's duration starts to wear off very quickly. Can you hear?
I reduced it in between.
Can you hear?
I can hear, yeah.
Okay. So there is a wearing off phenomena. The medicine's effect starts to wear off much earlier than what it used to, and slowly and steadily the duration of the treatment starts to go down. The other thing that happens is that the therapeutic window, which means that the level of the drug within the blood, if it crosses a certain threshold, it starts to create unwanted side effects like dyskinesias, which I showed you. So you need to keep the drug within that therapeutic window. You don't want it to come lower than that level, concentration level in the blood, and you don't want it to go above that a certain level. And as time goes by, this window becomes narrower and narrower. So one of the things that needs to be done is to start giving frequent medication and lower doses so that you don't have wide fluctuations in the blood levels. You give frequent medication in lower doses. So instead of giving one tablet thrice a day or one tablet 4 times a day, you can give half a tablet 6 times a day. And that tends to make the level more smooth, and the on and off phenomena tends to get a little better. That's one of the strategies. There are many other strategies, but there's not enough time to go into that.
So will you tell me, Mukul, what is the role? Is there a role of Botox in treating Parkinson's?
Not really. Botox is meant mainly for dystonia. For Parkinson's, it doesn't have much role. And maybe in some very isolated case of a severe dystonic situation happening in a patient, the early morning dystonia is known to occur. This is known as the end of dose phenomena. Patients get up when the medicine effect has worn off, and they get up with a painful dystonic cramp or contracture happening in one of the feet. So in that situation, one can give Botox in that to relieve that, and that will affect for about 4 months. After that, when one will have to repeat it. But usually changing in the dosing and using longer acting medication, which you give in the night, which tends to work till morning, that works better than giving Botox.
Great. Now tell me, I think, when you look at DBS, you spoke about DBS, and there was a very impressive change in the gentleman who had undergone the DBS. Now, are there any specific criteria that you would apply while offering DBS to somebody?
Yes, DBS basically does not work for atypical Parkinsonism. For MSA, PSP, corticobasal ganglion degeneration, those it doesn't work. It's basically meant for Parkinson's disease, which is the typical variety. And one of the criteria is that the patient should be responsive to levodopa. If the patient responds to levodopa, then probably he's going to respond to DBS as well. And the patient should be in motor fluctuation stage, where basically you want the current stimulation to have a constant effect, and it's not a varying effect. And therefore you can stop that on and off and motor fluctuation by DBS. So these patients respond better to DBS. And of course, if somebody has intolerable side effects to medication, then he becomes a candidate for DBS.
Great. Now we see many of these are elderly people who might be on medication for several other medical conditions. Now, would you be able to name a few drugs which might either react with the anti-Parkinson's drugs, either in terms of making them more potent or less potent?
Yes, one has to avoid taking dopamine blockers. So like metoclopramide, Perinom, and Stemetil. Even nowadays, patients have a lot of constipation, and for that they take a drug called levosulpiride. And levosulpiride is known to block the dopamine receptors, and levosulpiride can cross the blood-brain barrier, so it can block the receptors in the brain as well. So one has to avoid these kind of medications because they will definitely aggravate Parkinsonism. Many of these patients have psychosis, and you have to avoid the typical antipsychotics cannot be given because they are also all dopamine blockers, and they will worsen Parkinsonism. Only a few atypical antipsychotics are okay to give, and out of them, quetiapine and the other is close-up pin. These are the two ones which can be used safely in these patients, and we use them quite often.
Great. I think, Mukul, I think this has been tremendous. I think the way you've responded very, very lucidly and very briefly to the questions. I'll just move on to Professor Ranjan. I think the way you showed us the way therabands are used to strengthen various muscle segments of the body and the importance of frequent exercises with the adequate gaps that you mentioned. Now, will you tell us, is there a particular category of patients, a particular age group, or a particular type of patients who need a particular set of exercises? Or is it that you would do an overall strengthening for all patients and not necessarily focus on a particular group of muscles? Dr. Ranjan.
So as you are talking about the specific group, then it is depending upon the stages of the Parkinson's disease. And if the stage 1 is there, then we can delay the progression by the exercises and with the help of the medicine. And in that condition, this type of strengthening exercises, flexibility exercises, and the musculoskeletal flexibility exercises, these are very important. That till stage 3 it works, and in stage 4 and 5 the on and off phase is there. It becomes more challenging at that time to treat this type of patient. So as Dr. Mukul was telling, that when there is a effect of lower levodopa, then on phase is there, and at that time we can perform the exercises to maintain the muscle properties and the flexibility of the muscles as well as the movement of the joints and all that. So that time it will work. But as soon as the patient goes into the office, wearing off is there, then he again gets bedridden. But we have to maintain the muscle property so that whenever there is on phase, he should be able to perform the task as per his ability.
Right. See, you often hear about disease modifying treatment, which needs to be started before the motor symptoms occur. Now, for somebody like me who's a non-neurologist, see, I think recognizing a lot of Parkinson's, many of us perhaps notice the motor symptoms earlier, and possibly the non-motor symptoms might be visible only to the trained eye. So is there a particular advice you could give all of us to say, which would be the warning signs or signals where somebody should suspect Parkinson's?
So as far as non-motor symptoms are there, then the caregiver or the patient relative, they do easily identify that, oh, this problem you are having. So the patient's relative, caregiver, they should be more attentive, because loss of smell, loss of taste, this can be judged by the patient himself. He can say that I'm not able to smell those things, because, and other family member are able to, they will say that something smell is coming, but the patient will not be able to smell that. So he will come to know that some problem is there, and at that time he can consult any of the experts of the medical fraternity, and at all the investigation, all that will reveal that. Non-motor function are the early sign and symptoms, and if you will see, then writing, sometime there will be problem in writing. Cognitive level, the cognitive level changes, that are those important things which we can look for. And a proper you can say symptom can be seen by the patient relatives or their near and dear ones only.
Great. Is there a way to identify a subgroup of patients who may have more autonomic effects amongst the wide range of Parkinson's patients that one sees? Mukul, would you like to take that first?
Yeah, so patients, the atypical ones have a worse autonomic involvement, especially the MSA patients. But of course, Parkinson's, like I showed in non-motor symptoms, many patients of Parkinsonism have a lot of autonomic involvement. and we can do an autonomic battery of tests like postural hypotension, SSR response, sympathetic skin response, the RR interval variation. All these things can be done to see which patients have got more severe variety of autonomic dysfunction.
Great. You hear about this newer thing called the ultrasonic cranial therapy. I mean, what is the current state on that?
So this is basically lesioning. Like I told you, you can make a lesion in either the GPI, which is the globus pallidus internus, or the subthalamic nucleus. And up till now, we were doing lesioning by surgical methods, but now we've got focused ultrasound. And basically, with the help of magnetic resonance imaging with MRI, you can target a certain nucleus in the brain. And with the focused ultrasound, you can first give a short stimulation. I mean, a short, a low intensity beam, which will make that area glow on the MRI. So you know that you're on your target. And then you give a high intensity beam, which is focused from various angles onto that target, which destroys the target. So basically, it creates a lesion in the GPI, causing the same effect that a deep brain stimulation does. The difference is that deep brain stimulation can be done bilaterally, whereas at the moment it's not advised to do a focused ultrasound lesioning on both the sides. Number two, it is best for tremor dominant variety of Parkinsonism because they are the ones who respond better. And some studies have done, and certain studies have also shown that, and in US they have started doing high frequency focused ultrasound lesioning of the brain, especially the GPI. And this can be done in a single seating. One goes in a single sitting. One goes to the MRI, gets it done, and then comes out. It's a non-invasive procedure. I think it's going to cost about 5-6 lakhs. So it's cheaper than deep brain stimulation, but you can't undo it and you can't program it.
Right. Coming to that, I mean, Mukul, I must tell you, I mean, I'm a urologist. So several years ago, we all got very excited with high intensity focused ultrasound in treating prostate cancers. I mean, it comes with its own pros and cons.
Yes.
Now, when you talked about the programming part of it, now when you have somebody who's had a DBS, if somebody needs reprogramming and who lives at a remote venue at this point in time, what is the state of the science today with remote programming of the DBS?
Yeah, now we have programming which can be done through the net. So it can be done. Programming can be done over the net. The patient can be visible on a video and as an online real-time video, and one can change the programming parameters sitting in your place, and the patient may be hundreds of miles away or thousands of miles away. As long as he's got a good internet connection, programming can be done now.
Okay, now, Dr. Ranjan, can I just ask you, if there were 3 things that you would advise me or anybody else to do to slow down the progression of Parkinson's, apart from obviously modifying the drugs as required, what do you think I would focus on?
So focus on aerobic activities, focus on flexibility, focus on maintaining the strength of the muscle.
So that is extremely useful. Now, are there people who are on treatment who might be drug intolerant? And how do you deal with that?
Yeah, there are people who don't tolerate the drugs at all. Now we know that there are many varieties of Parkinson's disease. We first used to think there's only one variety, but now we know there's a tremor dominant variety. We know there's a postural and postural instability and gait dominant variety. And then there are people who are very, very sensitive to levodopa. They have a lot of intolerable side effects with levodopa. So these are the patients where you have to go very slow with the medicine. You have to start low and escalate it very slowly. These are the patients who may respond better to other medication like dopamine agonists or amantadine. And of course, the role of as Dr. Ranjan has spoken, has got a very big role to play in these patients, and these patients may also benefit with deep brain stimulation. But fortunately, these kind of patients are not common, and so we don't kind of we have most patients who do respond very well to levodopa and the other medication, and of course these patients have a worse outcome.
Sure. Dr. Ranjan, what is the role of the core stability exercises in Parkinson's?
So core stability exercises helps you to maintain the posture of the body, because posture is one of the factor which deteriorates fast, and that leads to a postural instability, as the subject is stooped and there is slow gait and the common fall is there. So it may prevent your fall and as well as maintain the posture.
Excellent. See, I think the next question would be partly addressed by both of you, I think. The first one is the progression of the disease after deep brain stimulation, number one. Number two, the role of physical therapy with a focus on the same patient after the DBS. Maybe you could take it in sequence, Mukul.
Yeah, so the progression of the disease still continues even in spite of deep brain stimulation. And the beauty of deep brain stimulation is that you can change the parameters as the years go by. You can reprogram the patient so that he kind of goes on to keep on the benefit, can go on for 10 years, 15 years. Now we have rechargeable batteries, so we don't have to replace these batteries, which would normally have to be replaced after 5 years. So, but there are some studies which suggest that because of deep brain stimulation, there may be a slight retardation in the progress of the illness also. Not everybody agrees to these studies, but there are studies which show that. But it doesn't halt completely, that's for sure.
Great. Dr. Ranjan?
As Dr. Mukul said, that reprogramming and parameter setting is one of the important part in DBS. And when it is done, then accordingly the flexibility of the muscle is there, and we can assist the subject in getting the strength and all that. Because programming is very important, sir. If it is accurate, because sometimes what happens with such programming, patient is not able to perform the task or whatever exercises we are trying to demonstrate or trying to get from the patient. But as the programming is set, patient is comfortable, he is able to do the movements, and as he said that the progression is still on, it will be on, but surely it will help in leading a good quality of life of the subject.
That's right.
I think it's very, very interesting that through this evening, when we have had a wide range of subjects related to Parkinson's that's been covered, what Mukul was talking about, the rechargeable batteries available, it looks like most of us have our rechargeable batteries and haven't lost on energy yet. It normally, I think, is a testimony to the quality of the speakers, and both of you, I think, have been outstanding. I think both in terms of the subject matter and the brevity and the clarity in the way you have come across with your answers. With a virtual meeting, I think it'll be important to finish with a virtual question on the virtual treadmill, the availability and the expenses. But before we go into that question, I want to also thank the very disciplined participants. The participants have been excellent. The questions have come through the chat, and very, very fine and well thought of and good quality questions have come through. So I think to me, this has been one of the outstanding participative programs. And on behalf of the Neuroaid Research Foundation, like with everything else, one of the biggest and the most important points in any service that you offer is the awareness. The awareness about the variety of neurological conditions, the awareness about the access to the treatment, the awareness about the availability of the treatment, the awareness about the affordability of treatment, and lastly, the knowledge that organizations like the Neuroaid Research Foundation are focusing substantially on taking care to a different level with a state-of-the-art neurorehabilitation, particularly with a focus on those who need it the most but may not have an access or may not be able to afford that treatment. So I think before we close, I would request Dr. Ranjan to comment on the question on the virtual treadmill. Dr. Ranjan.
Sir, I didn't get the question, sir. There was some.
Sorry, I'll repeat the question.
Yeah.
You know, the question on the availability and the cost of the virtual treadmill.
Okay. In India, sir, if we are looking for the virtual things, then it is a bit costly in terms of other countries, Western countries. And still, I think it is developing, and in India, lot of, there is no, you can say that still it is in a starting phase. And in coming future, we can see that if a lot of practice is being done, lot of equipments are being bought, then hopefully we will be having the lower cost. And our Prime Minister is also very much keen in having Make in India program. So later on, if the facilities and this technology develops in India, then definitely the cost will come down. Right now it is very costly, and sometimes it's cost around 1 to 2 crore also. So hopefully in future, as technology is developing, we will see that this will be a very accessible thing for all of us.
Excellent. So what I would like to say now to all of our participants of this wonderful evening would be, for all of us to be able to move properly, a lot of drive, we all need to be driven by good quality muscle tone, muscle exercise, where necessary by medication, spot on diagnosis, great help with multiple partnerships. But then we always come to a question of what drives organizations. Organizations like the Neuroaid Research Foundation, which many of us have been extremely passionate about, both Dr. Mukul Verma and I have been fortunate to serve on this as trustees. But like I said, when there is a lot of functionality and functions happening, there is always a driving functionary. A driving functionary whose passion goes beyond any limits. So I just want you all to see the person who always remains and enjoys staying in a shadow of things. But I would love you to see the chief functionary of the Neuroaid Research Foundation. Raji, would you like to just move towards me? That's Raji Chandru. Raji has been the driving force. The entire organizational structure, she goes well beyond her working hours, her working commitments, and driven very strongly by the passion and the emotion. So you and I know that whatever can be achieved by various methods of treatment, various kinds of strengthening, will really take us very, very far. But the emotional connect and the passion, the drive, is what makes you and I sit here on a Friday evening and see where we can take the world to the next level. So while you and I go home for a wonderful weekend, think about how much difference you can make to somebody else's life. Raju, would you like to say something?
Thank you, participants. This was the first of a series of webinars, and we promise to bring you much more interesting webinars so you and I can partner. Thank you so much.
Thank you, ma'am. Thank you for inviting me.
Thank you all so much. Thanks for the participation. Have a great evening and a great weekend, all of you.
Thank you, Raji. Thank you, Subra.
Great, lovely.
Thank you.
Thank you, Dr. Mukul. Thank you, sir.
Thank you, Dr. Ranjan.
Yeah.
Thank you, sir. Thank you very much having
Thank
you
you.
here
Thank
on
you.
the platform of NRF.
Thank you, sir.
Yeah, thank you, all the people who have made this possible.
Yes.
Yes, especially, yes, Swapnil, Ujjwal, thank you for your help.
Thank you,
It's
sir.
been a wonderful working with you guys. Thank you.
sir.
Thank you, sir.
Okay, we're done. Not at all. It's good. I mean, good.